And now it's time for Q&A and discussion. And for this, we have a panel of 4 oncologists really interested in this area. Those are Margarita Magem, Ernest Nadal, Enrique Carcerene, and Edgardo Santos. Please come.
Neoadjuvant treatment is not a downsizing of the tumor, so it's not a rescue treatment. So what are the reasons to use it? Because so far, the neoadjuvant data haven't convinced me.
I think for me, if you would change the surgical approach, is what we prompt a decision.
But have we any data from the neoadjuvant trial that there has been any reduction on the planned surgery following the neoadjuvant treatment?
We don't have that data, no. No, we don't have that long-term data. So to be, as I say, to be determined yet. It hasn't changed yet.
What do you think about the protective therapy up front with a highly active agent as osimertinib in avoiding early progressors into the brain? Is there any data on that from the neoadjuvant trial that may us to?
At this point, also hypothetical. We know CNS penetrance is good for osimertinib, but as I stated, the data is still very immature, and the long-term outcomes haven't been presented yet about CNS benefit, about the benefit of adding the chemotherapy. I have used it in settings in which the multidisciplinary team agrees that will change the outcome. But as I say, it's not ready for prime time yet. But we're starting to begin the conversation.
Yeah, this is a very important question, Martin. The neoadjuvant, we also need to have the biomarker analysis of the neoadjuvant to also recognize what patient we should not use osimertinib up front, because we also have seen some kind of resistance from the beginning on some of those patients. I like your presentation, Narjos. There was a question that you put, what patients should receive chemotherapy? Okay, so remember that when talking about the DAURA part, okay, let me jump quickly before I forget, because this is important. When the DAURA trial was developed, as all of us we know, was not with the idea of saying, oh, you have EGFR, you should go on osimertinib for 3 years. The idea was to give chemotherapy to everyone. In that sense, we failed. But there has been also studies on recognizing your population on stage 1B. And I want to bring this up because we are just waiting, hopefully, that the NCCN approve a test that was presented this month in the panel, which is the risk reveal. We've been using that technology for a while, okay? And until today, believe it or not, we have not had the idea of, oh, you have a stage 1A post-op, you should be fine, and observation and still is category 2A. I think that we have to change that, okay? And this panel, I love the presentation of everyone. Lorenza, you did a terrific job. There are a lot of gray zone, and we need to change that, otherwise we will never move the bar of survival. So when I see a patient, even with a stage 1A, I would say, this is critical, you are not cured. We need to figure out which patient have really a bad biology. So the same thing happened with EGFR mutation. On EGFR mutation, this technology called risk reveal also identify that this test, which is a gene expression profile, doesn't have to do anything with EGFR. That was proved by the colleagues from Connecticut, by Dr. Woodard. That was presented in the North American ISLC years ago. And until today, a lot of people have been skeptical until last year, the publication from Lancet, okay, was published by Dr. David Spiegel and colleagues. So we hope that in the next NCCN update, we have this technology being signed by the NCCN that we should use. So the risk reveal is basically for stage 1A up to stage 2A. What patient really needs chemotherapy? That will answer this kind of answer. So we need to move this forward. And I just want to mention that because all of us, we do lung cancer. And again, the only way that we can move the survival and start to cure patients, even with stage 1A and stage 1B, is to recognize this 25% of the patients that has very bad biology.
Thank you. Yes. Dr. Mayen and then Dr. Nadal.
I have one question for both. You commented that neoadjuvant treatment is not for unresectable patients, but what happens with patients who are borderline and we don't know if maybe with a neoadjuvant strategy these patients can be resectable? Do you think that LAURA strategy is the best, or you can try with a neoadjuvant strategy?
I think what we have learned about those patients defined as borderline is they're often no Foley stage. And I think having EVAs is extremely important for those patients that we're like, oh, we don't know. I think invasive staging is very important to draw the line and adequate staging, like the lymph nodes have enough tissue, you have enough lymphocytes. Because a lot of that we see in our tumor board are patients that are borderline resectable, but when you do the EVAs, the N3 was positive, right? But if they are borderline resectable, I think they're those N2 bulky disease, because the definition of N2 bulky is very variant. I was in a surgical conference recently, and I asked 15 surgeons, and I recorded them, and I put it in my talk. What do you define as N2 bulky? And I got a response that was different for each surgeon. So I think, like Edgardo mentioned, having that gray zone of what borderline is lies in the bulky N2 and no invasive staging. When you cross those two lines, then if you truly have borderline resectables, are only a few of them. And those few, I think it will depend on the location of the tumor. Where are we talking about central? What is the surgical approach that would be possible or not? And the performance and the subgroup mutations and co-mutations too. That's what the NGS. So I think we can now say it's black or white, every borderline resectable that is truly borderline resectable, which I think is only 10% of what we define as borderline. All these factors take into account. And also what the patient wants to do, I think is very important. So it's a very long answer to a very complicated question.
But I think so we have done the bridge trial in the non-oncogenic rhythm, and I think it's exactly the same question, saying in these patients you can give 2 cycles or 3 cycles of the fluoride regimen, and then you see what's the real role of radiotherapy. I think this is the essential question. What's the role of the chemoradiotherapy in EGF receptor mutated locally advanced non-small cell lung cancer? And I think it would be interesting to have such a trial concept also in the oncogenic-driven non-small cell lung cancer.
And I think you have patients that you think they're going to go to surgery and something happens and changes right in those scans before. Right now I have a 42-year-old patient that we thought we were game. We're no gain anymore. So then we have to, bring the radiation oncology approach. And I think the journey of early stage has become a journey, and we have to have stop points. And the patient needs to understand that it's not definite they're going to surgery, because you break their heart. I don't know why, did you just say, oh, surgery is not going to be possible now, and you're just like, ugh, right? So it's a journey, and we have to have a step points in which we call the surgeons, we call the radiation oncologists, and that's what I truly love about early stage. First, because it balances it out treating young patients, so between a 22 and an early stage.
I want to add that something very important that we're discussing is the staging is not well done necessarily, because for example, the staging is pretty much worldwide based on the PET scan, if it is available. But you have a patient with a negative PET scan, squamous cell carcinoma, and if you do the EVAs, you may find something. So that's why, for example, in our center, every squamous cell carcinoma patient with a negative PET scan, they get an EVAs before surgery. So we are 100% sure what is the stage. Even the adenocarcinomas, if it's more than 3 or 4 centimeters, if you have a negative PET scan, you may find something positive in the EVA. So that's why I think part of the problem is the stage is not well done.
Yeah, and just to add to that, the patient had driver mutations, particularly ALK. The tumors can be very small, and they can have very significant lymph node burden. So that's what, and between PET scan and EVAs, there's a 15% discrepancy in which the PET scan was negative and the EVAs was positive. So.
Yes, exactly the same. Sorry. This proposal we published the results of our series 3 years ago, and we found that occult metastasis N2 is particularly frequent for ALK-positive disease. And this is something that we can consider when we think to operate this patient. So for future strategies.
Yeah, I think that, I think that everything has changed, okay? We're living in a very complicated world right now. And this issue that Raes was explaining about MRD is wonderful. I mean, we have the technology there, we need to use it. The issue of personality is going lower than 1 million per particle is the way to go. I mean, the technology is advancing so quickly and is so rapidly that the clinical trials are behind. My last patient, one of those patients I have with REP, it was a patient that has a PET negative, and it was the one that was able to find the patient ready to go for surgery, was a stage before that with PET negative and everything, but it was positive also on liquid. And that's another concept that we need to change. In my opinion, perhaps maybe I'm wrong, but I don't know, if I found a patient with ctDNA positive in the blood, for me, I'm sorry, that patient have systemic disease, okay? That's it. I don't care what the PET scan show and everything. If you are ctDNA positive, you are a systemic disease. So those are the kind of clinical trials that we need to start to look in the future and not to be so nihilistic, like, well, you know, a PET scan negative and those kind of things. We need to move from that era.
I have a comment coming from the Martin skepticism about the NeoDaura that I share, but it's true that for, the mindset from many MDTs changed with the uptake of chemoimmunotherapy, and I think for some surgeons now, going to surgery directly and with an N2 disease is very controversial too, and I think when you have a biomarker or you have a ALK positive or EGFR mutant positive disease, I think going directly to surgery to do adjuvant osimertinib or alectinib, for us, for example, is a bit uncomfortable because we suspect that some of these patients, they will have systemic disease. This is why, despite the results are not very compelling, and I think that the study is still mature and we need to wait a bit more, but I think on the other hand, for me, going directly to surgery is not ideal because some of these patients, they could progress quite early, and some of them, they have multi-level N2 they require sometimes larger sections, and I think there's field for improvement, and I think the companies should invest more in academic studies to try to explore which is the role of neoadjuvant TKIs, exploring, for example, what Dr. Magen said, borderline resectable, or trying to, why not, extend a bit in breast cancer, patients receive hormonal therapy for 6 months. And why not extend a bit the therapy to try to reduce more the tumor? I know that could be provocative for some surgeons to wait and for some MDTs, but I think we need to investigate more, and I think these studies are also great to understand why the tumor don't respond completely. And that we have seen some data coming from osimertinib and adjuvant studies that the drug persistent cells are there, and trying to understand why they don't disappear. I think that would be nice, and that could give us some clues for metastatic disease.
That's why we really need the MRD, because, for example, now when we're doing research in MRD, it's amazing and surprisingly worrisome that you have now patients with perfect surgery that come to us for adjuvant therapy that is empirical, because we don't know who is cured or not. And now I have a lot of patients that are positive. They have a perfect surgery, early stage, the MRD is positive, and you see that during the adjuvant therapy how the MRD clears. So in the future, that's the way that we have to do it, because to doing an empirical and a CAT scan every 3 months, you're irradiating people doesn't make any sense. It's because we didn't have anything better. But now we have something more rational that we can do to help these patients. So.
Yeah, but probably we need better drugs, no? As you mentioned, because the pathological complete response rate is so low with this scenario in which we expected a high pathological complete response. So it's the first step, no? A question from Luis?
Can I say something? You have talked also about the sandwich possibility to treat patients with sandwich possibility. However, according to the MRI, if we have patients after neoadjuvant treatment that we don't achieve a complete ctDNA clearance, it's necessary to continue with the same drug, or it's better to change the drug with, nowadays for EGFR, we know that we are in metastatic setting with a combination. I don't know if we can start with osimertinib and we don't have a ctDNA clearance at other combination or at chemotherapy could be an option. And also, if we have to wait to see the overall survival to decide if this combination is good or not, or we can use some surrogate endpoints, could be an option.
Yeah, that's a very good point, because I didn't have a chance to say that. For example, I don't know if you said the publication. There is a group that, I'm trying to remember where it is, they did the Pacific, and as you said, they start to check the ctDNA when you start the Durva. And when the patients didn't respond, they stopped the Durva and changed to chemo.
Yeah.
And now we're trying to show that there is a survival benefit, but it doesn't make sense. That's the reason, what she just said. We do Pacific and we only cure half of the patients. Because even with the Durva, we're not curing everybody. So.
Spanish Lung Cancer Group is carrying out a trial in this setting.
Just to add to that, the thing is, what is after osimertinib? I know Luis,
sorry,
we're coming
Luis
there.
wants to talk.
Is that the next agent in early stage or followed MRD, I worry about is the juice, where's the squeeze, right? So you have a patient in the adjuvant setting, osimertinib, you have nothing in scans, you have a positive MRD, and switching to amivantamab certainly worries me about the balance between benefit and quality of life with no scans. I think if we have something similar to osimertinib, I will do it. I just worry about the quality of life with no positive scans. Yes, it's an MRD, but it would be very hard. And I don't know how many surgeons would like to do surgery after 4 cycles of amivantamab with the risk of clotting. But I think we need something more than osimertinib and amivantamab. I think this is just the beginning to push more in that space.
Luis.
I'm sorry, but I'm going to come back to Neodaura. So I think Neodaura didn't define how to treat patients, but tell us something. Let's say, I mean, we know that, if I'm having a patient which is wild type, if my patient is N1, even is resectable, I'm going to try chemo-IO first. If it's wild type, if it's EGFR mutant, and my patient is N1, I don't know. If it's N2 for sure, I'm going to do neoadjuvant treatment. Because it's a standard of care. And if I'm doing a neoadjuvant, after Adaura, before Adaura, I tend to use chemo plus OSI with empirical basis. Now it's a bit more than empirical. So I'm not saying it's better, but chemo is the standard of care in the neoadjuvant setting in that patient, and EFR is not worse. So I'm really happy, and also having the data from the metastatic. So I don't like to delay the start of osimertinib, and that is the reason. And chemotherapy is part of the treatment. The same for me in the adjuvant setting. If I'm having a patient that has been operated, then I learn is EGFR mutant. I'm going to do osimertinib for 3 years, but I'm going to do 4 courses of chemo if the patient is eligible. And I'm not going to do 4 courses and delay osimertinib, which is the good drug for this patient, for 3 months. I'm just going to do everything together. And after 4 months, after 4 courses, I delay chemo. So, not having a phase 3 trial showing that doesn't mean there is no some evidence to really guide our clinic, at least for N2 patients. You can discuss on N1 or whatever, but I think for N2 is...
As you are a Galician guy, your answer are always, what do you do with a EGFR N2 disease, borderline resectable disease? So what is your answer for your patient?
Very easy.
Okay.
Chemo-OSI, 3 months, CT scan, go back to the MDT, and we see what happens.
No Laura scenario, no chemo, radio, and then OSI.
I think we have debate for next year.
Okay? Who agrees with Luis with the strategy?
This is what...
Where are the radiotherapy colleagues?
This is what we call consensus. Yeah. Where is Federico? Yeah. And I will join Lorenza's team. No, because we don't have a phase 3, we need to do that. In the recent congress that we have in Miami this weekend, as my colleague Sosinski said, so at this moment, for your team, Al and ROS1, we need to extrapolate. We are not going to do this, I put patient on durvalumab. If you have a stage 3, after chemo radiation, I think, sorry, you go as well as you, alectinib or taletrectinib, and we move forward. Yeah.
I think also that with
Martin.
I love this. Yes.
So we were just here, I think, more in the hesitatious corner because the PCR rate of osimertinib is poor. And just giving osimertinib for 4 months and then asking the MDT what they are going to do it's based on the radiological response. It's not based on the biological response. And I think, Daniel, you make the comment, do we really change the biology in this type of disease? Would you like to add?
No, so I agree with that. And I think the challenge is hopefully there'll be more neoadjuvant regimens to come, and we'll have more convincing readouts of systemic regimens that may give us higher PEF-CR rates, that we have more conviction that it's really going to make a difference long term if they go for surgery.
But the question is, did we expect a lot of Neodora? I think we were, in my opinion, and I talk about the data, I was waiting for the data. We were all waiting for the data. And I think because we have Keynote 671 and everything else, it's different tumors, different biology. And I think Neodora suffered from being after that. And we were all so hyped up because, you know, osimertinib changed everything forever. And now we're like, oh, it wasn't as good, but it was still very decent.
Yeah, so the issue here is that we haven't got the strong data. The only thing, you know, when you got the strong data, it's very easy to be an oncologist. You don't need to be an oncologist. This is here getting the best use of the available evidence.
Correct.
I'm not saying this is robust evidence. It's not. It's just making some clinical judgment to that. Because the issue is, are we going to have clinical data showing that chemotherapy is useful in patients with N2 disease EGFR? Not at all in our life. This is going to exist anymore.
As an advocate, you also need data of, for example, radiotherapy on EGF receptor mutant.
I couldn't agree anymore.
We do not have that data. We just say we have a targeted therapy and that's the instrument for everything. We do not know. We even do not know the clearance by surgery. So there are many unknown points in this management.
My conclusion is that Luis cannot be part of any guideline team because he's outside of the guideline.
You know, one thing we did see in NeoAdora, while I don't think it changes the biology, and we're not seeing PCR rates, you did see a higher rate of people getting complete surgery with OC alone. That was worse than chemo and even worse than OC, or it was better than chemo alone, better than chemo OC. And so I think if you decide someone's resectable today, what we learned from the DORA is that these cancers spread early, that they're probably systemic much earlier than we think, and maybe getting that treatment on board, because you can't go to surgery tomorrow. So if I know someone's EGFR resectable today, why not give them OC while I'm waiting to plan, right? OC, I would do OC, yeah. It starts very quickly. I think that the rates of getting to R0 resection were highest with OC alone.
But if you have a stage 2 and 3, you know that you give the chemo. So why don't you take the safe way because you don't change the biology of going chemo OC? Because we have so much data from Raphael Rosel, by the way, 30 years ago, about neoadjuvant chemo in stage 3 improving survival. So why would you wait until surgery? It would be something which might give rise to some biological resistance. We don't have the data. Why don't you anticipate the chemo, right? So I would say for stage 2 and 3, maybe for the 1B you can discuss the 3 centimeters and above. But I mean from the N+, I would give chemo OZ, so you don't take any risk. Maybe you give OZ for nothing, right? But at least the chemo is done. Anyway, you have to give it. And you know that adherence and compliance is better before.
And you often cannot
actually, this is very good because we are now discussing chemo in EGFR, so we just need to discuss cis versus carbo.
We can start now.
Yeah, just to add to the chemo, some patients cannot make it to chemo after surgery. We need to remember that. There's a chunk of patients, 18% of those that cannot get to. I have a few of them that were like scheduled, and now other problems happen afterwards. So the neoadjuvant maybe, sorry Martin, that's still neoadjuvant.
And also sometimes surgery is delayed because in the public health system, patients need like 8 weeks to go to surgery. So I think that the neoadjuvant strategy is very good to control micrometastatic disease as well in this population.
I do have a question for MRD. As we are designing trials for the Shredder study, right, from Helena, in which patients are starting osimertinib, and if they're unclear in 6 weeks, we're adding the chemotherapy. Do you think we're going to start doing that with more trials? What do you feel about that? Because that's a dynamic adaptation of regimens based on cell-free DNA.
No, that's why the studies that I love the most, and I think they can change the standard of care, these escalation, de-escalation studies that we were discussing before. No? So that makes sense. Not only the first question, the answer is somebody, adjuvant, if somebody needs or not. So that will be answered by MRD. And the second question is, we will escalate or not, depending if we're having success or not with the treatment. It can be OC, it can be immunotherapy. In lung cancer, we're a little bit behind. As I show you, in colon cancer and bladder, I think with the bladder study, there is very, very close that they may get NCCN guidelines. Finally, it will be the first NCCN guidelines for MRD. It will be Signatera probably. I don't know if it will apply to Personalis because they're similar technology. But we need to escalate and escalate. There are several studies, that we're doing now, and hopefully, we need positive. But there are challenges. How many MRDs you can prepare? Not everybody gets MRD. We need better drugs. So there are other caveats that make this difficult for us.
I have a question for you. Considering that the technology is relevant, as you mentioned, the study from Dr. Natasha Leck and colleagues, with the first generation, the ctDNA positive rate was lower than with the second generation. How can we be sure that the technology is good enough for not prescribing treatment?
I think
because the problem is not, we can add toxicity when adding a treatment, but the other is, okay, I think this patient is cured, is not need for any additional treatment. Do you think we are in that position now?
For example, in the bladder study, that's what happened. In the bladder study, people that was MRD negative didn't get any treatment. From, I think only one patient fell or two patients fell. So that was a false negative. Yeah. The other way is, okay, you're MRD negative, you don't need chemo. But for safety, we do several measures. And so that's why in 3 weeks you're negative, and maybe in 6 weeks you're positive. So that's why for safety we can improve the safety, enhancing. The other thing is, if you think about it, we are only 25 years behind hematology, because since the year 2000, after a bone marrow or leukemia induction, they don't care what the pathology said. The pathology said, oh, this is a complete pathological response. They still give chemo if the MRD is positive. But the MRD that they use is 1 in a million. That's why I think hopefully we're reaching now with the whole genome sequencing and the FAST, we are finally reaching in solid tumors 1 in a million, because until recently we were using, for example, Signatera, the original Signatera with 16 truncal mutation, it was 1 in 100,000. No? So that's why now that we have 1 in a million, maybe we can imitate only 25 years behind our hematology colleagues, and now we can use the concept of forget about complete pathological response. Now we do for molecular remission.
I think the main limitation for MRD, my personal point of view, is that it's just only prognostic. So it's telling us who has the highest risk of progression, but it's not informing us about what is the best treatment for that patient. And that's why in colorectal cancer, the liquid biopsy failed, because they have very poor treatments for the adjuvant setting, and it's not informing about what kind of treatment. So it's a high-risk patient, yes, it is. This patient needs a treatment, but I need informed data to take treatment decisions. For instance, if an MRD is positive, but it's informing me that it's a clonal or subclonal MET amplification, and that can trigger a treatment like amivantamab that can block not only EGFR, but also MET. And that helps me to choose the right treatment for that patient, and that translates to better survival, then liquid biopsy could be easily adapted. Otherwise, it's only prognostic. And we can use the peptide uptake. There are many prognostic factors out there that we use in our clinical basis, but we need to implement the predictive factor of the MRD in our clinic. That's the main challenge from my point of view.
But I think that to what Narjos asked, I think that we are already on prime time to escalate therapy if the patient is only on osimertinib alone. That's my sense. You are on osimertinib alone for those that will not move forward to FLAURA2 for XY reason, or Mariposa for XY reason. You start with osimertinib, check the MRD. If you are not clear, I think that this is the prime time to escalate therapy and the chemotherapy in that moment.
Yeah, there was in ESMO, you know, you saw with the songertinib, Heimak, I think, presented MRD data, the variant allele frequency. This was not ctDNA, it was variant allele frequency. And he showed that by cycle 2 on songertinib for HER2, pretty much all the patients clear. Yeah. But if somebody doesn't clear, maybe that's the patient that needs to escalate.
Absolutely, yeah.
So we are on time.
One question that probably we need to address is which is the clinical, because we don't know yet the length time from the molecular positive detection to the clinical appearance of the disease. Then another controversial point is we need to learn more about this natural history of the molecular positive disease before designing studies that are interventional studies, taking that into account. Are we sure that that some of these patients with positive disease are all progressing, or maybe some of them they could be for a while without any recurrence? That's something that maybe we are becoming, I don't know, we are becoming very aggressive to implement this, and this is one question that we need to address.
So with this last comment, I want to close this session. Thank you very much for your perfect presentation and for nice discussion. And now